Thank you everyone for joining in, and I can see that there are a lot of DM and DNB trainees as well, and everything what we have learned in geriatric oncology is because of the initiative taken by Vanita ma'am. So I think she is there in the panel, so I am too small to ask question to her, and she can actually tell how to go ahead and guide us. Also now various other now Asian Geriatric Oncology Society is also coming up in our country. Hopefully, not only TMH and multiple other centers throughout the country can have the geriatric oncology clinics. And I think Tarachand Boss has been one of our guide who started geriatric oncology clinic at Jaipur, Bhagwan Mahavir. At TMH Varanasi, we were definitely having the ability to start because of the guidance from TMH and not only from Vanita ma'am but the entire team actually. So I'm thankful to the entire team who have guided us and helped us. So this is a panel discussion from this was slides are from Kumar Pravasar's unit, and I can show a case. This is a 67-year gentleman with no comorbidities, cigarette smoker and occasional alcoholic, presented with history of right-sided chest pain from 6 months. A scan showed a right lobe cavitary lesion, multiple non-necrotic nodes in the mediastinum, and biopsy was in favor of squamous carcinoma from the lung. That was positive of CK7 and P40. PET CT did not show any other metastatic lesions. So diagnosis is 67-year gentleman, performance status 2 with right lung non-small cell lung cancer, T4 disease, node negative M0, and T4 is due to chest wall invasion. So if we see this guideline, what is to be done, how is to be done, it tells that any patient with disease where you can offer surgery, the surgery is usually given, but in such cases where it is node negative and disease is large, there is an option to give CTRT, and there is an option to use neoadjuvant therapy, chemotherapy followed by CTRT or other modalities. So I will take first comment from Tarachand Boss. So sir, how do you take such patient in your clinic? This is a patient, you can see the age is 67, performance status is 2, plan for curative intent treatment. How should we move ahead for such a patients, and what do you do in your geriatric oncology clinic before bringing because you are not sitting in geriatric oncology clinic all the time, you are sitting in your routine OPD. So how do you start the workup, and how do you take that patient to your geriatric oncology dedicated clinic?
Akhil, usually for geriatric oncology clinic, till now we were running a OPD geriatric in the same OPD and in which I am sitting. But from Monday onwards, or still we have started work, that from this Monday onwards, we will be having 2 clubbed OPD. One, both will be run by me. One will be for the exclusive geriatric patients. And presently, this is 75, but within a month, we are going to down the age by 70. And second, for this case, I was just reading the guidelines of SIOG for the lung cancer, even to 2010 and 2013, that they advise that if the patient is quite fit, then the patient on the basis of age should not be debarred from curative intent. And yes, if the patient is surgically fit along with all the parameters, then patient can be taken up for the surgery. Because in a T4 stage, I think CTRT is also another option. If patient is not fit for surgery, then CTRT will be a good option.
Okay. So as highlighted, the very important is about the SAOG guidelines which guide us that if a patient is fit enough to receive a treatment, it should not be denied based on only age, because we know that age is a number. I think we saw some presentations where the ages of the 2 prominent figures were compared. They were similar, but the age is looking to be quite different. So it's just not about the appearance, it is about the physiological functions. So again, there is an important aspect of the patient expectation. Ma'am, can you guide us how should we take the patient and the caregiver expectations before starting and planning any treatment, because I think that is somewhat lagging in the busy OPDs, and your guidance on that.
Sure. My apologies. I think Dr. Parekh had given a talk on this, which I got stuck in traffic. I think a lot of us got stuck in traffic today, so my sincere apologies. But yes, absolutely, the patient's viewpoint is very important. And I think in our setup, trying to get the patient's viewpoint is difficult because usually the relative or the caregiver comes in and says, please don't tell the patient that they have cancer. So we need to discuss first with the caregiver and the family that, this patient is the one who's going to get the treatment, and it is very important for us to understand what the patient's priorities are. And priorities vary from person to person, so there's no one answer. A patient like this who is a bit frail, and then that frailty we'll have to decide in the geriatric assessment. But if the patient is frail and their non-oncologic life expectancy, meaning if that patient did not have cancer, what would their life expectancy be? And if that life expectancy is relatively short, putting a patient through something like a thoracotomy or chemoradiotherapy with neoadjuvant and adjuvant chemotherapy, maybe 1 year of immunotherapy, that is a very long discussion to be had with the patient. How much of quality of life and how much of detraction in quality of life, how much of toxicity are they willing to accept for a prolongation of survival? So that has to be an individual, so we call it shared decision making. So I think that's how we go about it.
Yeah, so as ma'am highlighted, shared decision making is important, but it's actually difficult in a lot of our patients because either they do not know, the relatives do not want to disclose the diagnosis, or they are sometimes not able to comprehend the situation. That is also a very important problem, but I think a team effort and counseling can help these patients, and we can get the importance of the expectations from the patients. So moving further ahead, this patient was seen in the clinic, MDT, the medical surgical radiation oncology and other teams saw the patient together in view of chest wall invasion. It was difficult to achieve R0, so the patient was planned for definitive CT-RT, and patient was seen in medical oncology clinic and referred to geriatric assessment. So that is how in our assessments we do. Patients usually get referred to medical oncology clinic and goes to geriatric clinic. Usually, most of the time, medical oncology team sends the patient to geriatric clinic. Anyone else would like to comment whether patients come from other specialties also for geriatric evaluation, for example, from surgical teams, radiation teams? We are trying to establish that. I think under guidance of ma'am, we try to do that, but it's not yet very relevant, very common in our setups to get referral from surgical and radiation team for a geriatric evaluation for their decision making for surgery or radiation. I think anyone would like to comment? Dr. Prem?
Actually, pre-surgical evaluation, whatever the surgery, is quite common in geriatric practice. Of course, surgical oncology, I mean, I work very close with medical oncology, so it's more with the medical oncology setup. So what happens is when the surgical, either they have already done surgery and they come for chemo, or they are obviously planned for surgery, so we don't have direct contact with the surgeon, that setup. But in usual hospital practice, I think pre-surgical, pre-operative, peri-operative care of older person, assessment, intraoperative and post-operative is quite common in geriatric practice.
So we need to understand that, and this message should go to all the surgeons and radiation oncology colleagues as well, that geriatric assessment is not only for planning a systemic therapy, it is also for all other therapies. Patients who are being planned for CT-RT, they will come to medical oncology and they will definitely get geriatric evaluation. But this is relevant not only for systemic therapy but other modalities as well.
Dr. Akhil, can I add?
Yes, please.
So usually we were getting referrals from medical oncology, but as of now we are also getting referrals from surgical specialties, especially the urology side and the GI side, and that also for patients who are above 65-70 years of age, means older age group, and if they are frail especially, they are referring pre-surgery for evaluation.
Yes, I'll just add to that. The reason is that we are planning a study on prehabilitation. So when you have to plan a study at TMH, you have to present it in all the different DMGs. So we presented it in the different DMGs, patient who was older, and we do prehab. So prehab is just fix the problems that are present before surgery. So do physiotherapy, fix the medications, comorbidities, things like that. So I think it became a bit popular and they were all very excited. So we have not started the protocol, but we are getting now patients pre-surgery.
So that is how the institute evolves and the practices evolve with time. And it is important, as ma'am suggested, it is true most of the time we are able to improve the outcomes through planning some studies actually. So that is the way it is important. So if you cannot do a large study, a randomized study, do a simple quality of life study, which we learned from Kumar sir and Vanita ma'am, and we try to do it under guidance of Mishra sir at our hospital as well. So that is really important. Always try to get some type of study running at your institute so that you can prospectively follow up the patients. Because when you see a patient concurrent multiple times through the journey, you will understand what is happening to the patients, what are the toxicities that is hampering the quality of life, and how is the outcomes and other family members, caregivers burden. Everything you will tend to understand then. Otherwise, it is very difficult if you see a single snapshot of the patient. It's not very easy to understand. So that is a very important problem also during the DM and DNB training, because you will be able to see the patient as a snapshot, but you will not be able to prospectively follow up because you will be posted in other units during the follow-up. So that part is lacking in the training, and that can be taken care in the other post-DM part or post-DNB part that is important. So I think that is one of the exception which is required. So the patient underwent a geriatric assessment. The Rockwood CFS was 6/10. Any comment from the our geriatricians? Yes, Abhijit? Yeah.
So, like you said, this is a snapshot.
Yeah.
Now, we can say that the patient is having moderate frailty, but now you also mentioned he's having chest wall invasion.
Correct.
So maybe the limitation in activity could be because of pain. So identifying frailty is not the end of the assessment. Identifying frailty is the beginning. After identifying, we need to identify why he's not performing these activities. Then we'll find out what is the reason and we try to fix it. Like if it is pain, then adequate pain management might actually taking up to even 3, which is managing well.
So it is important. The very important point brought about by Vijit was that we need to see the patient, but just by the look of the patient, you cannot decide what treatment has to be given, which has been the usual paradigm previously, but now we understand it is not about the look of the patient, not about the age of the patient. We need to understand the cause of it and act upon it. And after improvement, we need to reassess what treatment we are going to provide. So that is very important point. So this patient has G8 of 10, VES 13 score is 7. So for the benefit of the trainees, can anyone highlight the importance of G8 and VES 13 for the geriatric oncology evaluation? Anupam ma'am?
Should
Anyone can take.
Do we have a next slide or?
No, this is about just brief introduction to G8 and VS13 so that the trainees who are available can understand what is being written.
Yeah. So G8 and VS13 both are screening tools to identify people who are vulnerable and who may benefit from geriatric assessment. So G8 score less than 14 says that the person is frail. And whereas VES13, anything more than 3 is considered as being frail. G8 looks more into the nutritional aspect. Most of the questions, the 8 questions, are into the nutritional aspect, whereas VES13 is more of physical functioning. So that's why we see that the Rockwood and the VES are almost in line in this patient.
Yeah, thank you. Thank you for
Just to highlight, so there is no complete scale. So let's not just go on scores. Because if you see, all the 3 might tell us something, but G8 is more nutrition specific, VES13 is more activity specific. CFS will tell you, yes, frailty, but not necessarily the cause. So as you said, you need to not only look at the patient, you also should not only look at the scale, because ultimately you need to assess what the scale is telling you and then plan accordingly rather than just seeing the scale or the patient. Both go together.
So just wanted to add to that, Dr. Akhil, just the context of this. So all 3 are frailty assessment scales, and G8 and VES, and why this use is because you need to screen the patients. All 3 of them are used in various settings, various places. So some people use VES, certain settings use G8. Now they are used mainly to screen the patients to look if they are frail, and then to send them for a geriatric evaluation. So basically that is where all these 3 scales come into place.
Yeah. And also in resource constraint setting, when we cannot do geriatric assessment for all the patients, as we showed that 1% of the patients who are of geriatric age at TMH are able to be screened in the clinic, those the situation might be gradually improving, but it is still a very long way to go. So it is an important tool actually. So ma'am, your comments on that?
Sorry, can I?
Yeah, please.
Yeah, so this geriatric assessment, we have recently started in my setup, which is a private hospital setup. But G8 and West is something that we are not commonly using there. And of course, I'm not assessing cancer patients very commonly over there, because it's just all geriatric patients.
Okay. Ma'am, your comments on this?
So I totally agree that in the current setup in our busy hospitals, doing a geriatric assessment for all patients is difficult. It's difficult because you can't do it as part of assessing the patient. You have only a few minutes to assess the patient, which is the reason why you need a separate geriatric oncology clinic. Just like you have a separate anesthesia fitness clinic. It's not done in the routine clinic. And I think the admin has to understand that this is something that is important. It's not, it's not impossible. If you have enough of people who are going to do the assessment, and it does not have to be a physician, it can be a physician assistant or a nurse or a resident or, it's a relatively simple thing to do. So I firmly believe that this is an important part of assessing an older patient, and we are doing a disservice to our older patients with cancer if we are not assessing all of their vulnerabilities. And that needs to be, I think, with enough of voice and enough of saying that enough of times, hopefully that will change.
Yeah, definitely. And one more point about the modification of G8, which was studied in our own study.
So the normal global cutoff for G8 is if your score, G8 is a screening tool. So it's a quick thing, maybe in 2 or 3 minutes, maybe not even 1 or 2 minutes, you can do the G8. It's a series of questions. And if the patient scores 14 or less, then that patient, less than 14, then that patient is considered vulnerable and needs a full geriatric assessment. That's the global cutoff. So we found that if you use that 14 cutoff, then almost more than 90% of our patients were vulnerable. And then so that it was pointless to do the G8 and then do the geriatric assessment. So we lowered that score to 12, and below 12 we found maybe around 60%. I can't remember the exact number, but we had a good differentiation that those patients are frail, and then we followed them up and found that those patients had a significantly poorer survival. So it did correlate, so a G8 in our setup of 12 or less did correlate with more frailty. So in our clinic we are using 12.
So that is important to understand. We need to adapt the scales as per our requirements and the setups. So in India, we found that in our setup, G8 of 12 was corroborating more closely with the outcomes and also the need of full geriatric assessment. So we cannot do geriatric assessment for 100% of our patients. We need to find the exact patients where the geriatric assessment, because it's a long exercise, it takes teamwork and effort of all the members. So I think that is one of the innovative way which we could devise and understand that yes, this adapting the scale to cutoff of 12. So altering the cutoff of an established scale in our setup is also useful, one of the useful way to identify the actual benefit from that scale. So this patient has a geriatric syndrome of insomnia. There's no urinary incontinence, good corrected vision with the spectacles, and hearing is not impaired. So this is hearing handicap inventory for the elderly. So again, coming to this HHI, how this is important? Any would like to take that? Yes.
I think in this particular patient, of course, it's negative, but I mean, hearing is one of the most important things. I mean, we have been hearing the word quality of life since the time we started. So there are 3 things which are very important for quality of life: vision, hearing, and teeth. You can give all the diets, and the person doesn't have teeth, cannot eat. Hearing is one of the very important things which you might actually realize even when the person comes in. So if it is obviously positive, then it's also something which can be corrected. I mean, as simple as ear wax. I mean, ear wax is very common in all age groups. In older people, even more so. There have been people who have come to the clinic, clean the ear wax, they can hear pretty well. There is huge inertia by older adults to actually put a hearing aid. Whereas if you very clearly see there, I mean, nobody denies wearing spectacles.
Yeah.
But
Correct.
hearing, and nobody denies wearing teeth also. A lot of people are okay with teeth as well. But hearing is something which is a very touchy topic. But it's important to look for it, because a lot of times we have this attitude in general, I'm not saying anybody or any specialty in particular, to put it, no, it might be because of age. No, it is something which can be corrected. And if corrected, helps you in your treatment, because it helps in the quality of life as well.
Yeah, so that is very important. There is something called social taboo, and patients are very comfortable in wearing the hearing aids. But now I think there are so advancement in this field also. The hearing aids have become so smaller that it is hardly can be able to see. So hopefully this will become more socially acceptable and utilized in more number of the patients, and it is important to understand and highlight this fact to our patients so their quality of life is not hampered during the treatment or after the treatment. Yes, Dr.
It's also become more expensive, I think, the hearing aids, especially the smaller ones. At least when I tell my patients, they feel that they can hear more louder after putting the hearing aid. So it becomes a bigger problem for them, which they don't like.
Okay.
That's why most of them actually, a lot of ENT patients only come to me because I know the doctor and he sends across the patients to me because most of them are geriatric, so they want an assessment.
Okay.
So that's how hearing aids are a problem.
Yeah, so I think the patient has already adapted to low amount of hearing, and now when we are correcting it to normal after utilizing hearing aid, that is causing some difficulty. So I think again there is a need of fine tuning instead of just putting it to correct normal frequency. So
I think there is a need of good education about the hearing aids. There needs lot of tuning or synchronization things to be done. Of course, it's very expensive, but less expensive ones are also available. But then we do not have good information and knowledge about these hearing aids.
okay.
We need to work upon this, need to collaborate with the speech and language therapist or maybe hearing specialist for this. This is what I feel.
So it's
There is a lot of need because
Yeah.
the old people are suffering, they are not able to hear. I think we
Definitely,
need to work
completely
upon
agree.
this
So
area.
I think these are the untouched parts which we try to touch during our geriatric assessments, but to act upon it is a very difficult point. So doing assessment and then not acting on it is as good as not doing assessment. So it is important to act upon it, and at least patients and caregivers should be given a choice and guidance on how that can be adapted. I think Vanita ma'am tried to bring about that point in multiple publications. How should we act upon the findings of geriatric clinical evaluation? Because we do so much of assessments, but if we are not able to act upon it, it becomes a difficulty. Ma'am, I request your comments and some examples also.
No, I totally agree, and particularly hearing, vision, walking. Lot of the patients, when we find that they don't have hearing, in fact, vision is something so simple. Lot of the patients who come from the village or even just come to our hospital, they don't wear the chashma. We check their vision and it is 6/60. So I said, how can you see? They said, बस ठीक है, जितना दिखना है वो दिखाई देता है. So, and they don't go to the ophthalmologist, they don't put hearing aids. So I'm not sure, it is probably, it's an attitude, and we are so focused on the cancer care that all of these fall by the wayside. And we don't have an ophthalmology department, so they don't go. We do have a hearing department, but they don't go. So, and I totally agree with what Anita and Manjusha said, that the hearing aids, the good ones, are like in 4 or 5 lakhs they cost. The cheaper ones, there's so much of background noise that it's very difficult for the patients to adapt. So I don't know the solution to it. I totally agree. Assessing it and not acting upon it is pointless.
Yes.
But I don't know the answer to that.
Actual answer, what should we do? Definitely, at least highlighting and guiding the patient is actually important. And yeah, please, John.
Dependent that they don't need any thing for themselves, because there are so many people to help them, that if they are visually also they have issues, they have people in the family to help them or assist them with their daily lives, so they don't need any help from these added aids.
Yeah. So that is yes sir. Yes, sir.
Just to re-emphasize, because my parents are 93 and 90 years old. They are living independently. There's nobody else living with them.
So it's about the entire social structure in which we are living actually. It is not about just finding a problem and then acting upon it. It is about the attitude which our patients and the upbringing which is there. So I think that will continuously change with time. So now here is the symptom assessment scale, and we can see the depression score to be 3 out of 10 in long-term symptom assessment score. So I would request Lekhika ma'am to highlight about the various assessment scales which we utilize in our geriatric clinic and how to act upon it.
It is very important to assess that mood symptoms, and in lung cancer that prevalence of depression is quite common. So to rule out the depression, there are other scales also like PHQ-9. So that with the help of this, that patient health questionnaire, but for elderly patient, that this is geriatric depression scale, that the cutoff is 5. So if we that find it out that the score is that and it rules out depression, so patient needs to be assessed further for psychological intervention. Yeah.
Okay, thank you ma'am.
And for our elderly patients, that scale should be that much feasible to understand, So we need to make it easy and to make it understand each statement to the patient. Thank you.
Yeah. Thank you, ma'am. To highlight this, the psychological part is actually sometimes missed in the practice, and it is very important to diagnose it at the correct time and act upon it as well, because that is a very important problem. Just to touch, please.
I just wanted to know, because we are very much familiar with application of DAS in our department. Just wanted to know, is DAS applicable for geriatric patient? If no, why?
Actually, DAS is this combination of depression, anxiety, and stress, So that, we don't use actually DAS. GDS is, feasible and easy to for specifically for elderly patient. DAS is for everyone. Yeah.
Okay. Just to touch upon the nutritional aspect, so I would again request Sarika madam, Purvi ma'am for the comment. Yes, ma'am.
If we go to see in the nutritional aspects, there was an unintentional weight loss which was very much, that is 13%, which was seen. But if you go to see now MNA is a validated nutritional assessment screening tool as well as an assessment tool for the geriatrics. So what it says is the first 6 questions which are there is the screening tool which is there. And if it goes more than 7, the score goes, then you're supposed to go further ahead with the next 12 assessments. So if you have a score which is more than 24, it comes as a total score. The patient is quite well nourished. If it is between 17 to 23, the patient is at risk of malnutrition, and anything below 17 is severely malnourished. So, but if you go to see, as the patient showed a score of 19 as the total score to come in, so he was at a risk. But so this is just the beginning. You have to do a further assessment with the MNA to go in, because this is just a start to it. So if you go to see the case, because there was severe pain, which will again affect his appetite. The appetite score was also 5 to 10. So again, that was there. There was insomnia, which is also seen in these patients. And of course, 13% weight loss, because if you also see the grading, it was T4. So most of the advanced cases, there is cancer cachexia which sets in as it is because of the severe appetite to go. So even in our practical, the geriatric assessments that we do, as rightly as ma'am said, the practical aspect is the way to go ahead is the pre-rehab that we do. And as and when the patient gets assessed, it's immediately seen. So with the MNA score, the at-risk patients are the most vulnerable, because they have a higher risk to go ahead for being severely malnourished. So in practical aspects, when you are able to detect these people and start a prehab, at least, prior to 10 days, prior to the treatment, if you're able to, in our setup, in our geriatric assessments, the clinic, we immediately get the reference. because we have to psychologically also deal with it. Along with this, we have to take their recalls. So, they become quite comfortable by the start of the treatment which happens. So that is there.
That is actually very important, because it is important that our patients are already tuned to the adaptations which are required from the geriatric clinic, so that can be taken care of before starting treatment.
Yes.
But that is actually very difficult, because all these assessments and actions will take some time. So
Yeah.
it is at least important that they can be started at least with the starting of the treatment.
Yes.
So that is important point. Just to very briefly highlight about the importance of polypharmacy, Dr. Bharat, if you would like to highlight the importance of polypharmacy and what should be done to manage that.
One of the things with the advancements in healthcare is that most of the patients, they tend to cross certain ages like 60, 65, and as we are presently discussing geriatric. So by that age, we can say that in a way that we collect a lot of comorbidities with us, and oftentimes they are not reviewed upon. Certain medications which would, for example, like certain proton pump inhibitors, once started, they continue like forever.
Yes,
and
that is very
often
commonly
they are.
seen.
And often they are even taken like just on an SOS basis, just self-prescribed. So a good medical reconciliation is required in such patients. A very hefty history, sometimes certain drugs, the patients, they tend to omit, considering that probably they are not required to be told here. For example, some drug which would have been started a day before, the patients will omit that. So, there are certain other medications like outside of the allopathic regime. There are other medications as well, but there are drug-herb interactions as well. And so turns out that many patients, they have even like 10, 20 medications going on. And I think there is no rationale to have that much of drugs to be given for a patient.
That
so
needs to be counseled, and we need to take care of that.
Yeah.
If a patient is having around 7 drugs ongoing and you find that 2 to 3 drugs are not required, definitely we can stop that. But if it is a doubtful benefit, how should we go about? What is the message to the trainees? How should we select the drug which is important or non-important is not correct for a geriatric patient?
The rule of thumb is less is more. Like as less as we can go, and it also depends upon case to case basis. Often it is like there is no set rules, because our bodies don't behave like in a very absolute way. So it depends from patient to patient. Sometimes there is also hit and try, that probably 2 drugs are going on. Maybe if you could omit one of those and let's see how it goes. So
So
keeping it at least less than 5.
Yeah, so it requires a fine tuning and it's individualized decision. Yes, ma'am.
I just wanted to say that a lot of the medications that are ongoing, so for example, hypertension medicines, diabetes medicines, when the patient starts on chemotherapy, a lot of that requirement goes down. So many of the patients' blood pressure goes down and they do not require those 3 or 4 BP medicines. They develop, they're not eating, they have anorexia, they are vomiting, they don't require all of those diabetic medicines. So it's really important to keep track, because many of the patients then end up having hypoglycemic episodes. And that is what is more life-threatening to them than actually anything else. So it's important to go through the medication list and deprescribe. Many aspirin, statins, all of those are prophylactic medicines. Now this patient has advanced lung cancer, so probably doesn't require the statin which will lower their risk in 20 years, right? So I mean that is what we need to take a look at their medication list and deprescribe.
So polypharmacy is not only about the number of drugs. There is something known as essential polypharmacy and there is something known as non-essential polypharmacy. So if people have comorbidities, a lot of times they might have to have that. But what is important is what is the status of the comorbidity at this particular age and when it was started. So if a person had CAD from 40, that doesn't mean the statin has to continue till 85. So that's
why the drug review has to happen at different stages of life, rather than just thinking just because the cardiologist started something 40 years ago, it has to be there when the person is 85. Yes, completely agree. So that is an important point. We need to personalize. There's no single rule. There's no single rule and no perfect guideline can be made, because it needs a high amount of individualization. So this patient was started on concurrent chemoradiation, received CTRT, and had some amount of toxicities which were managed, and there was also some delay in the week 11, week 12 doses. However, the patient was had a initial resolution, but there was a new liver mets. The patient was started on low dose immunotherapy, and patient presented with heaviness and bowel obstruction. So there was a significant increase in the disease, and it becomes important to incorporate the early palliative care in such patients and take decision accordingly. So not everything goes as we plan. We need to take care of everything from the beginning itself, and counseling remains the key. I think we are running short of time. We need to stop here. Thank you, everyone. Thank you for the excellent participation from everyone.